So thank you, Dr. Kirti, for the invitation. Uh, when cataract gallops, when to basically how to proceed, and there's cataract galloping in. Cataract follows trabeculectomy. So Dr. Kirti has already told you actually is very frequently that after you do trabeculectomy, you end up with cataract within a few years time, and almost half of them will develop cataract within 2 years time. But the reported incidence goes as far as 78%. And the major risk factor is actually the post-operative period. If there is a flat anterior chamber, or if there's a post-operative inflammation, uh, or are there, or if you need any manipulation, the post-operative, if you use 5-FU MMC, maybe they also have some toxicity. They all increase the chances of cataract formation, and flat AC and alone increases it by almost 18%. On the other side is that the cataract surgery, if you do on an existing filtering bleb, that is a risk factor for failure itself. So both have a very difficult relationship. One leads to the other, and the other leads to the failure of the first one. If you look at the data, again, almost 18-20% cases, they will show some decrease in the bleb function, within a year or two after of the surgery. Sometimes it's hard to say whether there's a natural progression of the blebs or it is because of cataract. But cataract blebs which are doing fine otherwise after cataract surgery, they are kind of known to hypofunction or function less. And also, if at the time of the cataract surgery, if your IOP is higher to begin with, the chances are that you end up with more higher IOPs after cataract surgery than if the pressure was on the lower side. And people have used different ways to safeguard from this, including 5-fluorouracil, but that kind of remains a bit controversial. So this is one of the examples. We have angle closure glaucoma patients with high pressures and managed on multiple glaucoma medicine, anti-glaucoma medicines. Basically, pressure is still high. So he undergoes cataract surgery, and 7-8 months down the line develops cataract. And then we do phaco. After phaco, initially the pressure is okay, like 15 millimeters of mercury. And you can see in the immediate post-operative period, the air has gone into the bleb, so that's okay, that's not of much consequence. But you can see the appearance of the bleb is you can see these vessels there coming around, and some fibrosis, activity you can also. So you don't want to see this kind of picture. So that means there is going to be this, bleb might fail, because now that cascade has been activated. Once you have a scar, once you have a dormant scar, and it's kind of a balance is achieved. But anything you do to the eye, like cataract surgery, that balance is upset, and then you again has those pathways activated, which ultimately lead to more, collagen formation and ultimately failure of the bleb. So we use 5-fluorouracil, in the post-operative period to safeguard this. In spite of that, the pressure actually went up in the immediate post-op period, and it needed multiple anti-glaucoma drugs, one bleb needling, but essentially it subsided, in about 2 years. After 2 years, the result was not that bad. But this patient needed a lot of care in between, including bleb massage, 5-fluorouracil, and one needling. So you have to be, after you're doing cataract surgery, the message is that be careful because these blebs can fail, and you have to follow these cases more diligently, and they might need additional procedure to keep your bleb functioning in the post-operative period. This is another patient who had cataract, who had angle closure glaucoma again, and came with acute pressures. Basically, we managed. Pressure went down temporarily, but as you know, in angle closure disease, this can come up again. So patient needs filtering surgery, and you can see this is the post-operative period. Their sutures are there, and release. But this patient already had a bit of cataract to begin with. Now, at that time, one could have debated whether we want to do just filtering surgery or want to combine it with the cataract surgery. Maybe one could have done that too. But I think here the phacoemulsification was needed soon after, and you can see after the phaco, the pressure is good. But again, the surgery kind of failed, and needed filtering surgery again, within a short period of time. So this is another patient, again a little unusual situation. Basically, this patient was doing very well in terms of pressure control, but the blood was thin, and we didn't. It was not really leaking, but it was obviously thin, and probably there was a mitobacterium C bleb, which is a small and kind of cystic bleb. During surgery, it was uneventful surgery, but the post-operative, you can see the blood has gone back, and it has actually pushed the iris into this. Now, this patient had a floppy iris. So, if you are dealing with you have a filtering surgery, and if you have a floppy iris, I think you have to keep that also in mind. But even in the post-operative period, that iris can get dragged into a port, into the fistula, and then can cause. Now here it was quite obvious, but sometimes under the flap it may not be visible, and you might be wondering, what's happening. So do gonioscopy, and you'll see that your port is blocked. So that's another issue when you're doing cataract surgery after, and in the existing bleb, if it's already there. So what should we do? The question is how we can kind of safeguard our blebs against that kind of situations. So we have to take precautions during surgery. So one is that you identify the case beforehand, if there are any risk factors. Anesthesia is again important. We make sure that you have good anesthesia, and because as glaucoma patients, they are kind of at higher risk of optic nerve, damage. So it's a good idea not to use adrenaline to preserve the vascular reality, and also not to use too much of pressure like pinky ball and all. That should not be used in glaucoma patient if you do them for cataract surgery, but not if there's a glaucoma. Then you have to protect your blebs during the surgery, so be away from the bleb as far as possible when you're doing surgery. So corneal incision is good, and preferably the different quadrant where the bleb is. Then pupillary management, as I demonstrated with the case, is very important. Most of the time, these pupils are small. They might be synechic, and many glaucoma patients also have floppy iris. So I think that has to be managed well, because a floppy iris, if not handled well, could lead to post-operative inflammation, which will be deleterious for your bleb, as well as it could actually block the sclerotomy that you have already earlier created. So you have to take care of the endothelium, as we know. Stay in the capsule if there's any difficulty, so that to make the procedure easy, and always maintain the anterior chamber. Don't let it collapse during cataract surgery. And thoracortex removal has to be there, so that there's no post-operative inflammation or no material in the anterior chamber which can increase your pressure. And intraocular lens should be preferably in the bag. In the sulcus, there could be more inflammation, pigment release, and that could affect your glaucoma surgery. And of course, the complete removal of the viscoelastic is very important, because viscoelastic could get into the bleb and temporarily increase the intraocular pressure. Eventually, it will go out, but it could increase the temporary intraocular pressure and could damage the optic nerve. And also, it has there's a thought that if your pressure is going up very fast in the post-operative period, that could actually lead you to failure of the bleb. So post-operatively, you have to monitor these patients frequently, control IOP spikes, and use steroids with caution. So to conclude, TRAV is a significant risk factor for cataract formation. Flat AC, inflammation, surgical trauma are the factors which could lead to this. And cataract surgery is a risk to existing bleb function. So to reduce this, you have to delay cataract surgery if possible. Medical surgical technique, good perioperative care, and use of 5-fluorouracil, and some additional methods if required would be indicated. Thank you.